to Dr. Smith. So we're recording.
Fantastic. Well, thank you. And it's my pleasure to be included in this webinar so that we can hear about the comments and reflections of the REAIM framework now that it is a 20-year-old framework and something that we're all very familiar with. So I'm very much looking forward to this. I'm Matthew Smith, and I am the co-director of the Texas A&M Center for Population Health and Aging, and I have been included in the work group and with the REAIM framework for, I'd say about the last 6 or so years. I don't really know how much time it's been, so should have thought about that. But nonetheless, it is my pleasure to introduce the panelists today and allow them to go and proceed so that then we can have some rich conversation. So everybody, please, during this presentation, feel free to type into the chat box. I will be monitoring it, as will the panelists, so that we can go ahead and have some question and answer at the end and some open discussion. First and foremost, Dr. Russell Glasgow and also Dr. Samantha Hardin will be our panelists. Dr. Glasgow is a research professor in the Department of Family Medicine, School of Medicine at the University of Colorado, and director of the Dissemination and Implementation program there. He is among the top 1% of the most frequently cited social scientists in the world. Dr. Glasgow has previously served as the Deputy Director of Implementation Science at the National Cancer Institute and has been a primary developer of the REAIM framework. Dr. Samantha Hardin is an assistant professor of human nutrition, foods, and exercise at Virginia Tech and in the departments of obstetrics and gynecology and family and community medicine at Virginia Tech Carlian School of Medicine. She is also one of the few state-level physical activity promotion specialists in the cooperative extension system. She leverages these affiliations to promote the adoption and sustained delivery of physical activity promotion interventions. She applies the REAIM framework in community, clinical, and classroom settings and has been working with the REAIM framework since 2008 and part of the team hosting the website since 2012. So without further ado, I believe it's time to start hearing from the panelists, and I believe Dr. Samantha Hardin will be kicking us off.
Thank you, Matthew. And we're really excited about today's webinar because we are going to be discussing one of our very recent publications from March 29th in Frontiers in Public Health. Many of the folks that you see signed in were part of this effort. And part of the reason we wrote this paper was to summarize some historical perspectives of REAIM, as well as some current operationalizations of REAIM, including that REAIM can be used during the planning and evaluation processes of an intervention. And then also to talk about some current emphasis and future directions. And the way we have the talk set up today is that I'll talk about the first part, and then I'll turn it over to Russ to talk about the second part of this paper, really. So, and again, this is a 20-year review, so throughout the entire talk and our slides, we'll be highlighting some other papers that might be of a great reference for you, and we'll highlight them at the bottom, and these slides will be available on we-aim.org after. So to jump right in, many of you are likely familiar with the 1999 seminal paper where the call is to discuss why the development of such a framework is going to promote health. And one of the reasons is that, prior to 1999, a lot of papers were really focused on the efficacy of interventions rather than other contextual considerations or the potential effectiveness in other populations and settings, as well as long-term effects. And so one kind of layman's way of describing these 5 dimensions is that an intervention is going to be most generalizable if it can be adopted and delivered broadly, have an ability to be sustained and consistently implemented, so that high quality implementation, as well as at a reasonable cost for these different populations and settings. And then have a large reach, and particularly those for most in need of intervention. And then finally produce a replicable and long-lasting impact on behavior change. And although these things were a novel call in 1999, many of you on the call probably experienced that we're looking for interventions that still hit all 5 of these dimensions as we're trying to promote health or systems level changes. And I like sharing this fun fact that REAIM was originally going to be REM because you can't, if nobody adopts an intervention, so commits to attending training and then considering actually implementing in practice, we can't reach people, we can't look at the high quality of intervention delivery, and we definitely can't have impacts or long-term maintenance. And so, but REM doesn't quite roll off the tongue in the same way that REAIM does. And conveniently enough, with the hyphen, the reach and effect are at the individual level, and then the hyphen separates our system level dimensions of adoption and implementation. And the tricky part is that maintenance is both at the system level and the individual level. So, you know, on the way to perfection, but not quite perfect yet. So that's a really high level overview. I know when people say, as all of you know, macrophages are X, Y, and Z, I always think when I'm in that audience, well, what if I didn't know? So hopefully that's a brief background for those of you who are a little less familiar with this framework but have chosen to spend the hour with us. And a couple of things to really highlight why the framework came about is that, you know, we all have plans and then reality looks very different. We had joked yesterday that we wanted to post pictures of the 3 of us from 1999 to now, but I didn't plan to be sick and run out of time, and so reality looked really different from what our intention was. And we know that that also happens when we're trying to deliver efficacious interventions outside of their original demonstration trials and that audience and that setting. And one way to think about this is that if we want more evidence-based practice, we need more practice-based evidence. So as we take these wonderfully packaged interventions and try to make them work elsewhere, what really happens? What's the reality? What's the true story? And how can we be systematic in our planning and evaluation phases in order to really share that full picture, that full story with other people who are interested in either replicating or finding pieces of your work that's really impactful in their work. So some of the things that I am going to highlight just in our 2 very brief slides are regarding REAIM's use over time. And one resource, if you're not familiar, is to please head over to re-aim.org. On that website, we try to track a lot of presentations and publications, seminars, upcoming conferences, and those types of things. And I'd like to give a specific shout out to Dr. Nithya Ramalingam and Dr. Thomas Streyer, who are graduate research assistants who have helped us keep up with the website over time over the last couple of years. Because one of the things that we do is we update the site at least monthly and sometimes more than monthly, because we run a PubMed search for re-aim.org or just re-aim in PubMed and try to keep track of all of the publications. And if you go to the website in the search box and you're looking for a specific, maybe you're looking for school-based interventions or smoking cessation interventions, you can type that in. Excuse me. You can type that in and then find the publications that cited REAIM through the website. And as you can see through this figure, this has increased over time, and we know it's only going to improve from here. And then the next thing I wanted to highlight was network analysis of the REAIM framework conducted by Joanne Shoup and colleagues. And some of the key highlights of this social network analysis, as you can see, is that the use of REAIM has grown since its inception and has spread from few research centers to use internationally. Lots of teams have published multiple papers together. And one of the reasons that we're doing this webinar and wrote this paper that really prompted the webinar is because there are some folks on the periphery, and what we want to do with the REAIM work group and our website and this paper is to improve our communication with our target audience, which is many of you. And so we want to know what tools, what resources, what materials have been most helpful in the field, as well as what are some of the things that you need in order to, whether it be initial understanding of REAIM or continued use of REAIM during the planning and evaluation of your work. So we really want to move from this invisible college of this tight-knit piece, which we will still always be tight-knit and love the work group, but we also want to expand the reach of the framework, if you will. And then the final paper and outcomes that I'd like to highlight is this systematic review conducted by Bridget Gaglio and colleagues looking at the REAIM framework, systematic use over time. And one of the key highlights from that paper is this figure pictured here. And for those of you who are more text savvy, the thing that we are highlighting in this, or that Bridget and everyone highlighted in this figure, is that there was no trend observed in the number of publications that reported on all 5 REAIM dimensions over time. There was no increase over time in the quality or comprehensiveness of reporting when there were personalized REAIM scores for this specific study that they ran. So that's what the lines are indicating, is that while REAIM's use has increased over time, it's still a struggle to report on some of those contextual issues and to give that full picture that we're calling for. And so one of the ways to help us think about how we can start planning and evaluating and capturing the 5 dimensions. There are a number of resources that you can look at, and while some think we need to hit all 5 dimensions of REAIM in every study, some are also in the camp that say we need to prioritize which dimension is most impactful to move forward our work in the real world, as well as our empirical understanding of whatever target audience setting or health promotion intervention. And so one way to really start dissecting each of the dimensions is to use some more practical or pragmatic prioritization that has been recently articulated by Russ and Paul in their recent Preventing Chronic Disease paper, this wonderful table of, you know, what does reach mean? Really, it's who was the intended audience, and were those that we were trying to target actually invited? What did the intervention fit their needs? Did they actually come? And then what was the most important benefit you're trying to achieve? And were there any negative outcomes, and how do we capture those? And then from the adoption dimension, you know, where was the program or policy applied and who applied it? So even within adoption, there's that level of the intermediaries. So within a school setting, well, who is responsible for delivering the intervention within that school setting, and what were their characteristics? And for implementation, how consistently was the program delivered? How will or was, right, if you're using it in planning or evaluation, the intervention adapted? What were the costs, and why did the results come about? So this is trying to get at that, the nuances of what's happening when the intervention goes rogue in the field. And that's one of the reasons in my bio, we had Matthew share just the multitude of hats that I wear in the clinical community and classroom setting, and how REAIM continues to apply in all of that work. And that's what I have found in my research. And then the final dimension of maintenance, when will the initiative, so that program, policy, or practice, become operational within that system? How long was it sustained, particularly if we're looking at a time horizon of 5 years, because that's how long the grant is. Well, what happens after that, and are there opportunities to look back and see what was operationalized and what was sustained, and then also a real focus on how long are the results sustained at the individual level. And so within the initial operationalization, it was 6 months after the intervention receipt, what happens at the individual level for that health behavior change. And so this table is just a great start of having those conversations with your key stakeholders to understand how and what we want to capture if we're going to have the full picture. And then let's prioritize together and say, well, in this case, we really know that the intervention we're trying to implement, it has been effective for the last 20 years across a number of target audiences. So we feel really good about effectiveness, but what happens is once we do a training, people are really excited about it, but we don't see them. So they enjoyed training, they have positive program perceptions, and they intend to deliver, but then they don't deliver. So maybe we're going to really focus on adoption and then put our resources in both improving training or improving evaluation of training. And so we might be really focused on adoption. So with your stakeholders, you could use a table like this. The other thing is you can also grab a table like this and add a third column and make it very specific to your work so that you're sharing with your stakeholders, other researchers, or perhaps grant reviewers, how have you operationalized each of these dimensions, which pieces fall within the work that you're currently conducting or planning to conduct. So I think that this is one of the, within the paper with the 20-year review, we're really highlighting some of these resources, some of the gaps. There's also a table within the 20-year review that has examples of how people have operationalized each of the dimensions across a number of health outcomes. So please feel free to check that out within the reference paper here as well. And with that kind of brief overview, but hopefully a lot of resources and a lot of things to get you thinking about how you can apply or advance the application of REAIM within your work, and then things that you are thinking about for the future. These are some of the things that we thought about in the paper, and we'd love to hear from you after Russ discusses some of those key features. So with that, I'll turn it over to Russ.
Well, thanks, Samantha. My pleasure to be here, and good afternoon to all of you except for my colleagues on the West Coast. I assume if my volume is too loud or too soft, Samantha will let me know. Sounds okay. Let me just mention one other thing concerning this paper that's up there that Samantha mentioned, and also refer you to the table, because the table has, for those of you that are researchers, it has the latest technical definitions of REAIM. Samantha just showed you our pragmatic definitions, but for those of you that are concerned about getting beat up by study section or journal reviewers, that has the real technical definition if you want to do a comprehensive evaluation. And I'm going to try and rip through what I have in about the next 10 minutes. So that might be one of the things we might want to discuss, is this pragmatic, more selective use of REAIM versus comprehensive use. As you can see on the left-hand side in the box, I'm not going to read this to you, but these are some of both the current emphases that we have published and are working on, trying to get out there, and then some speculative future directions. But maybe most important, number 5, if I get done here soon, is we can interact with you, and we'd love your both feedback on our ideas and thoughts about where we can go from here. So next slide, Samantha. Samantha mentioned to you that REAIM has been used both for planning and evaluation. It's definitely been used the most for kind of post hoc evaluations, as you can see there. I really want to underscore that we have strong evidence now that REAIM can successfully be used before an intervention for planning too. And again, we might come back to that, but this is a little irritating because there's strong references going back at least 10 years, but still some reviewers say that you cannot use REAIM for planning, and that's just wrong. What we haven't done and are looking at now is more iterative use of REAIM during an intervention and to maybe guide adaptations or possibly even, this is a new bridge for us in terms of some QI activities. So next slide. So this is a slide we stole from Marcia Ori and colleagues, and it just shows you our trajectory and a few of the key issues that I'm going to briefly hit on today. Just walking along from the bottom of the arrow there is a greater focus on representativeness. We know that's one of the things that people haven't done, and we're trying to provide more resources and guidance for how to report on this issue of representativeness, not just at the REACH individual level. Most people seem to get that, but also at the setting level and the staff level and that sort of thing. Next button, use of qualitative and mixed methods to better understand the who, why, and how of that. And I think there's been a recent great paper led by Jody Holtrup and colleagues on that we'll make available to you. Going on up, this is one of the issues about pragmatic use, is the study of the relationship among outcomes on the different REAIM dimensions. And this may be one of the issues we'll want to talk about, but colloquially, I think the maxim is, I like to say, is you usually can't have it all. And what I mean by that sometimes if you put a huge amount of effort into effectiveness, which is what traditional research does, that's probably going to have reduced impact on REACH. What patients, participants, citizens can be reached or engaged, and also on adoption, a more limited range of settings that can adopt it, and vice versa. Ourselves, we've maybe been guilty of the opposite, designing something that's really easy to adopt and gets a huge number from an equity perspective, a lot of people, but its effectiveness is very limited. And then finally, more transparent reporting. And again, we have a new tool that's online available to you to help report more transparent reporting that we call an expanded consort criteria. So next slide, if you will, Samantha. So this is our take-home message. And I know it's a little small, but this figure is available in the paper, and one that we think we're going to use going forward that tries to pull it all together. We know it's complex, but we thought all of these issues were important to really understand how REAIM is being used today and hopefully in the future. And most importantly, on this slide, that if you want to order a REAIM t-shirt with this on it, you should contact Samantha. These are just hot off the press now. And so you'd be glad to get your order in. You can have a friend's rate, tell them you heard about it on the webinar. That's one of Russ's attempts at jokes. Those really don't exist, so don't estimate them. Okay, so let's walk through this slide, beginning with what's in the center. Our old REAIM dimensions, those haven't changed over time, 5 there, but we've now placed greater focus on separating out the intervention itself, and usually, as most of you know in implementation science, we at least argue that we start with an evidence-based intervention or evidence-based components, the core issues, and then those are delivered through implementation strategies. We're starting to focus more on that now, and then going forward, we want to try to understand and research which implementation strategies may be best to increase which REAIM dimensions. So next slide, or next build on this, Samantha. At the top is what we call our PRISM model, which stands very modestly for pragmatic, robust implementation and sustainability model. The idea behind PRISM is to provide some context for factors that may drive REAIM outcomes. And as I'm sure you all know that have struggled with this, context is both critically important and it means pretty much everything. And in fact, one person leader defined it as everything except for the intervention. So it's all very important multi-level factors, but that in some ways isn't helpful because it's so overwhelming. And what do we know? So in PRISM, we've tried to focus on some key issues to drill down, really realizing it won't be comprehensive. Like most models, on the left-hand side, we focus on external context or external environment. And some of the key things we think there that are most important are the policy and the kind of national level resources or guidelines that are put out for that. Moving over to the right-hand side, we really focus on multi-level factors. And as I'll stress a little bit more, the notion of the setting level, the intervention, and the patient, and again, for those of you that are more public health, translate that into citizen or just target user there, about their characteristics and perspectives, which are really equally important and that we're trying to get at more through qualitative things. And maybe most uniquely, that last, in the right-hand box, the last point there of what we term implementation and sustainability infrastructure. And again, we can talk more about that, but just to give you a little idea of operationalizing that, that has to do with things like existing resources once an intervention is done that are going to remain there. Things like, is there an audit and feedback system to track it? Is there somebody whose role, whose job description is to continue this program? Next slide, and on the left-hand part of the figure, we want to really drive home that there's not like one aspect or one magic thing about the intervention to maximize, or excuse me, the whole in a program to, or a policy implementation to maximize re-aim outcomes. It's really the fit or alignment among all of these factors that, you know, the intervention components, the implementation strategies that we're putting great emphasis on, both the inner and the outer context, and then the different re-aim dimensions, again, because of the relationships among the other dimensions. So this concept is both critically important and frankly, probably the hardest to drill down on, or if you want to think about identifying determinants or this fit. This is maybe the most, or the art rather than the science, and the most challenging thing about applying re-aim. But it's also the way that I think to really have an incredible intervention, what you need to do. Last, on the right-hand side are some cross-cutting issues that we're trying in the next slide that we called here overarching issues that we want to have as takeaways for you. And that is that across all the re-aim dimensions, there's a big focus on the proportion and the penetration that's involved there, to use some other implementation science terms. This isn't just for reach at the patient, but across all of the levels. That the notion is there, what percentage are they? And then in the second box, it's kind of a strange wrapping around the line. This is not a Nazi SS stormtrooper aspect, but it's the representativeness of who you're reaching. And again, that's equally, or in many cases, given the huge health inequities that we face today, maybe more important even is the equity of who's benefiting than the overall percentage. Middle box, as I said before, we're placing much more emphasis and trying to provide more guidance on qualitative emphasis of re-aim, so that we learn why and how, not just here's what happened, and often why we didn't do so well, but for future learning and enhancing generalizability, we learn in future directions, we learn how and why. Adaptations, as many of you know on this call from your names and have contributed, some of you have contributed seminal articles here, but this is so critically important because as Samantha showed on that first slide, never in the real world is something implemented or does it go as you initially planned. And we feel it's critically important, as Brian Mittman says, to not pretend or hide or suppress information about this, but to take it seriously and to try and understand it, and eventually to encourage or provide some guidance for, quote, appropriate, or what Shannon Sternman calls intervention congruent adaptations. Finally, that at the bottom is one of the things least often reported and probably most critical, certainly when you go to try and sell a new intervention or a new program to a new setting. The key thing they want to know about is, what does it cost me in my setting, and kind of what's the value proposition here? That, unfortunately, is the thing in the literature we reported the least often, and so we're trying to provide some resources and guidance for doing that. Next slide. If we could, we're going to end here with just a couple invitations for you. I'm going to do the first one and then turn it back to Matthew. We're going to be sending out an email the next couple days to those of you on here that we'd like to invite you to help us with an interview, a brief interview, if you have used REAIM in what we're calling, for short, real-world settings. And by that, what we mean is not a formal, NIH-funded project where you have $500,000 and a huge evaluation budget, but where you use REAIM for QI, for program evaluations, for projects where the primary goal really is to improve health outcomes, not to create generalizable knowledge. And there's a lot of things in the gray area, so if you don't know, you might respond to this brief email prompt, and we can help you kind of decide if this is what we're looking for or not. But the general notion is, where can you do in these situations where you have limited resources? We want to know how it's worked, what has worked and what hasn't worked. And with that, I will turn it back to Matthew.
Thank you for that. I certainly want to make another opportunity available and bring awareness to this group about a research topic, which is much like a special issue for a journal in Frontiers in Public Health. And we are coordinating this research topic about the use of the REAIM framework. And really what we're looking for and inviting are articles that document lessons learned, adaptations, types of utilization, innovative uses of the framework, but also looking to see if we can identify how REAIM has potential to advance science, practice, population health, all types of things, looking for things that are methodological, application in different settings, integration with other models, so many different things that would be welcomed. So if you are interested, we certainly invite you to look at the REAIM special issue, research topic from Frontiers in Public Health. The editors, even though my smiling face is there, and it's not really just me, there's multiple of us. This is a coordinated process from the group, including Russ and Samantha and Bridget and Borsika, Marcia, myself, and Paul. So there's a group of us coming together. If you have any questions, please feel free to contact me or send an email any other way. So moving to the next portion, it's time for some interaction, to hear from you, some question answer. Anybody who would like to pose questions, please use your chat feature. If everybody can see in their Zoom, there's a comment bubble looking orange bubble that might be blinking. It's the Zoom chat. Type in any of your questions. I'd like to go ahead and kick off a question. I can't believe that the framework is 20 years old, from 1999 until current, 20 years. That's quite impressive. And I guess my question for the two panelists, have the original definitions of the core dimensions remained pretty consistent over time, or has there been a bit of an evolution of how they're being used, how they're being defined? And for better or worse, how has that evolution changed the trajectory of research practice, policy, etc.?
Samantha, do you want to go first, or do you want me to take a shot at it?
I'll let you take a shot, and then I'll complement with anything else.
Okay, you can give them the right answer after I stumble along. Well, I would say, not to be a smart aleck, but I would say both, Matthew, or yes. And what I mean by that is, I think the core idea, or if you will, the principle behind each dimension has remained the same. We have thought from time to time about adding another initial, particularly a P for planning, when we found out that people were saying it couldn't be used for planning, but decided not. So those key definitions, and again, the table, I don't know, maybe if you want to scroll back, Samantha, the one table that we have there, the pragmatic use, the key definitions have remained the same. I don't think that we have dropped things out. What we have done to recognize the change in literature and reflect what we found with application of the model is we've added some things to it. So probably the best example is implementation. It always focused on how consistently was the program or policy delivered, and even we always used, even the oldest days, the awful word fidelity, that we focused on that. But over time, we've really added these other components to reflect the evolving literature, especially on those two things about adaptation. So we're looking now at the balance, not just fidelity, which is still important, but also adaptation. And we feel it's important to understand both of those. And then, as I mentioned before, cost. That was something that we added in. So in summary, I would say we've retained the original emphasis, certainly the purpose of the model overall, or framework, but we have added and probably increased the complexity a little bit over time.
Yeah, I think that's an excellent response. And I think that, excuse me, I think the only things that I can add to it is I teach a graduate level dissemination implementation science course. And I think every time I teach it, and it's only been 3 times, but every time I teach it, we're very overwhelmed as we're looking through the literature and looking through the number of theories, models, and frameworks that are available. We often have an assignment where we visit dissemination-implementation.org and search for, what's the target audience or level of intervention and all of these things. And I think it's really overwhelming for new dissemination implementation scientists or people who are trying to be in that world to figure out which framework works. And I often try to sit back and reflect, do I gravitate toward REAIM because that's what my PhD mentor was working with. For those who don't know, Paul Estabrooks was my PhD mentor. So I started working with REAIM as a very new scientist, and it made sense to me. And while there are many more to complement it, every single time I'm teaching the class, I try not to be really biased, but this is a simple way to look at each of these things that really influence both individual and setting level factors. And I think that there are more ways that we can talk about it, but one of the dangers of that is that there becomes so many different terms to say the same thing. So then, I don't know about you guys, but we often have a struggle with where, you're writing your introduction and you're doing so much definition, just, defining what you mean by the things you mean and sending to a lot of citations so that the readers are on the same page that you are, because you can use, scale up or scale out or uptake or translation or all of these different things with very different kind of meanings and definitions. So I think that I still gravitate toward it because it has remained so consistent and simplistic in my mind. But I keep saying simplistic, and then in the corner of my eye, I see one of our figures that often we try to make this as easily digestible as possible. But it's still really complicated, right? If you're doing this work and you're planning to use the framework before, during, and after implementation, there's so many different things to do within. And I'll just share one example because I know we have other questions coming through just with reach, right? So before, we plan to reach a target audience through electronic medical record reminders. But then we were finding that our clinicians were not engaging with that alert. And one of the nurse practitioners said, we need to just put a sign on the door that's at eye level when they're walking in to see the patient, because that might improve our reach. because it's a cue to action that's not in the electronic medical record. So we were able to assess, plan, do, evaluate, report on just the REACH dimension right then and there. So we're not waiting to the end of our grant and then, saying, well, we wish we could have improved REACH. So it is simplistic, but it's dynamic. And so I think it stayed the same in that way, but there's a lot of opportunities for expansion and tailoring for your work.
Those are really great points. And absolutely, I think, Samantha, you brought up a really good point about the need for common terminology, but often in cross-disciplinary work, interdisciplinary, transdisciplinary, whatever you call it, even having those synonyms and those integrations, it's difficult to identify and then prioritize what it is that we really want to focus on. So having those conversations and making sure that everybody's on the same page based on the framework, the metrics that would be included and how that's operationalized is so very important. To switch gears a little bit, there's a question that came in from Paul. How does the current push in dissemination implementation work towards addressing mechanisms fitting within REAIM framework and future research using the framework? So how do you see the current push in dissemination implementation work towards assessing mechanisms fitting within the framework and future research using the framework?
So Samantha, could you go back to the slide on the overall model to try and take a quick shot, and I'll try and be brief. As usual, Paul's gone right for the jugular. And for those of you that don't know, this is a somewhat active discussion among us here. I'll give you my bias on it, that Paul can respond and anybody else that wants to weigh in here. I think it's an important construct to understand if you look there at both the implementation strategies issue and then the contextual factors. I think that really, in an ideal world, if we're going to advance science, we would know, again, not only which implementation strategies to work for which REAIM outcome and which key contextual factors work if you address those. For example, if you address some issue of the internal context to address, say, leadership support, how does that work? Does that work through increasing social norms or some other mechanism? And I think those of us that are trained in theory would say it's really important to, for replication and future science, to understand not just empirically which of these strategies impact which REAIM dimensions, but what's the mechanism? What's the causal? That's the other term that a lot of people are using. I don't deny that eventually it will be good to get there. I do think that we need some new models of looking at causality. There's a whole lot going on, and I'm certainly no expert in them, but I do think myself that our traditional model, again, many of us were trained in using a linear, multiple regression or path analysis, is really overly simplistic for the real world complexity that we deal with. And I think that contextual factors are so critical, as are temporal factors and things, that it's really pretty challenging. So I'm looking at this evolution. I think it's important, but I wonder how much of our effort we want to put there, because there's so much else to do also. So sorry to go on so long. We'll try to be much more concise in the future, but it's not a simple question. Paul, do you want to respond quickly?
Sure. Yeah, I liked your answer a lot, Russ, and not surprisingly, we're fairly similar in how we're thinking about this. And you know, for me, I'm really excited about the prospect of trying to understand the why of the things that we do that lead to implementation outcomes that can be operationalized through REAIM. But I worry similarly to you in terms of a reductionistic approach that says, here's the path by which this happens, without understanding the broader context. And so, you know, my thought is that with REAIM and, you know, there's been a number of papers over the years related to qualitative research using the REAIM framework and some of these other implementation models. And I think that mechanisms are going to be things that we're going to want to try and look into, because I do think we want to try and understand how and why things are working. But just like you, I'm not sure that we have the most appropriate methods, kind of going back to the basic behavioral science and mediational models, which, at their best explain, 20 to 30% of the variance in human behavior. And so, now we're trying to take this up a level has some human behavior in it, but also has infrastructure and system and contextual factors that are independent of any human behavior, that also need to be considered in how our strategies work to, say, improve reach or implementation or sustainability of something within an organization. So I see it as probably a mixed methods approach that allows accessibility for all scientists to try and focus on this, and not just the scientists that are involved with large networks of clinics, that they can apply strategy X or strategy Y and then look at the outcomes, which kind of leaves behind, what I think is probably a majority, or if not a large minority of clinical and community settings that research will be, much like early efficacy research in behavioral science, irrelevant to the actual practice that's going on in the world.
I think the only things to share is this graphic. As someone who does this work in the community, I just recently shared, after a Society of Behavioral Medicine presentation by my doctoral student, Dr. Laura Bayless, who was sharing her work, we really tried to look at some key outcomes after training, looking at why training went so well and there was so much enthusiasm, and then there was this adoption implementation gap. So we had training satisfaction scales, we had intent to deliver, we had their re-aim perceptions of the intervention that they were just trained on, and everyone was really enthusiastic. And I should mention that Dr. Nithya Ramalingam was also leading that work. And everybody filled out the surveys and they thought it was great, and they all had really high intentions and all of these things. But in none of our surveys did we ask, did your parent or guardian just go into assisted living home? Did you lose a spouse or a child? And so those are the real world things that we can never capture in these mechanistic models. And so saying that someone, didn't deliver the intervention or didn't deliver it as intended for these reasons that we're trying to capture in our validated scales, it just gives another reason for qualitative data. But also, a lot of people are not going to disclose that in a focus group. So there's even parts of the qualitative data that are too rigorous that might not be capturing the full real world picture. So it's a real challenge.
Samantha, could I just ask you to scroll through some of the other slides? I know Matthew has some others to get to, and we'll try to do as many as we can, as quickly as we can. But I'm thinking right now of the maybe one of the original ones that has the paper on it. If people want to look it up, and some of the other issues. Then you can just go back and forth, including the call for papers that people might want to see.
That's great. And so thank you for this, and for Paul for chiming in. Great question. There have been two questions posed based on the topic of cost. One, I will be working on a new implementation-focused grant for infectious disease control, and we will use the C re-aim to highlight the inclusion of a cost analysis. Are there any favorite resources you suggest calculating cost, what to include, how to interpret the cost and benefits while not reducing human life and well-being to monetary value? And a second, also asking about an example of a model or paper where re-aim has been applied to measurement, operationalization, and cost figures. So questions about cost, how to capture it, how to operationalize, and any resources available.
Well, let me just try and take that one real quickly, so that we refer the person to the website. Two things come to mind. First of all, Deb Ritzwaller, R-I-T-Z-W-O-L-L-E-R, Ritzwaller, has led a lot of work on this in terms of some pragmatic ways of assessing costs and what she terms replication costs, which are often the most important. There's a more recent paper that actually provides some actual templates for how to do this, led by Whitney Rhodes, Rhodes. Both of those papers are available on the website, and I think, given the time, that's enough for that. Other than I will say that if you're interested in thinking about how does the cost involved on each of the different REAIM outcomes. Right now, we kind of just look overall, and as you see, maybe somewhat arbitrarily, we put cost under implementation, but there certainly are costs to all of the REAIM, to enhancing all of the REAIM dimensions.
Thank you for that. And, I think what this does is it actually brings up something really more about resources and how to learn more. We talk about encompassing and capturing 20 years of advancement and the life of this initiative. I guess one of my questions is, possibly Samantha, could you talk a little bit, just briefly, about the re-aim.org website and really just what it captures? Because that's really a great resource that people can just go to and answer a lot of these questions.
Sure. I'm just putting our Twitter as well as the re-aim.org on the website so that, or on the screen so that you can see here. So the website really highlights a lot of features. So we have checklists and tools. We've got publications, we have previous presentations, we have all of the webinars that we've hosted, recorded there live. So that would be a really great resource. And then, as I mentioned previously, within the publications tab, you can do a search and look for those keywords and also find the gaps in the literature. And so in addition to that, I'll come back to this highlights of use over time. This paper right here, the REAIM Framework, a systematic review of use over time, is a great resource to see how people were operationalizing each dimension and what about costs were mentioned. And then we, because some of these questions are really dynamic and there's so many resources to share, instead of putting them all in the chat box, when Thomas sends a message saying that the webinar is posted, we'll include the invitation for the QI project outcome that Russ was talking about, that's pictured here, as well as some of these resources so that you'll have them fresh in your inbox.
So Samantha, actually I don't have much to add other than if this doesn't exceed your multitasking skills, could you possibly go to the website and share your screen? And again, just thumb through so we can take some other questions, just kind of show them, you can maybe just silently scroll through, if possible, some of the different key pages and things that we have there.
Well, there's only one way to find out.
We can go ahead.
We might end a few minutes early, right? So another question has come in. Let's see. Well, as I'm looking at it, what trends have you seen in pairing REAIM with other dissemination implementation models or frameworks? For example, sometimes REAIM is used with CIFAR. Do you see an uptake in interest using PRISM to capture influences on outcomes that happen with REAIM? What are the implications of the newer, larger frameworks you shared that incorporate REAIM, PRISM, and other factors?
Yeah. The example that was given is probably the most frequent one that I see. First of all, in terms of published literature that's a little dated now, I think usually what comes up are diffusion of innovation, REAIM, and now CIFAR. It's a little more recent, increasingly. Just in terms of the choices, like Samantha, I really try to not just push people to REAIM, but ask them to think through what are the important issues, important constructs. Most often when people combine, and I noticed Orsika's Rabin is on too, so I might call her out if she's not doing something else, who can probably answer this better than I can. But using CIFAR for planning and then REAIM for evaluation is probably the most common combination that I see. That is certainly justifiable. I haven't seen people get into trouble, and that makes some sense. I think there may be other ways to either use REAIM in combination with, or maybe to contrast it. It's a challenge to contrast two different theories and models and do justice to it, but I think it would be great to see in the field if we go forward. One of the other directions, then we'll see if either Borsika or Samantha want to quickly comment, is that combining REAIM with some of the other reporting criteria, because we do have laid out again on the website, I don't know, yep, Samantha is going to it now, and some other tools to show you how we're specifying, if you will, optimal reporting on REAIM. But there are other things, like in particular, I'm a fan of the STARI criteria, the standardized reporting criteria, and one of the new tools we have expands on Consort. So I think that's one area that some of us would like to see REAIM involved with, is a greater congruence and integration with other reporting frameworks.
This is Borsika Rabbi, and I hope you can hear me well. I think Russ kind of covered most of what I could say. What I have seen most frequently is that people are comfortable with a framework that can give them help with planning or creating an intervention, but then they don't have clear outcome measures for implementation. And so then they reach out to REAIM to add that on to guide the evaluation structure. And I think that often they don't realize that REAIM could help them in the first part as well. But I think the combinations have been CIFAR with the REAIM very common. I don't know if I can list too many others where I have seen I have seen it with almost any kind of framework where the outcomes are not defined within the original framework, and then REAIM is felt to be a good evaluative framework. And then often we talk about it, and then Dr. Holtrop mentions here the PRISM, which I think is a nice extension of REAIM with contextual factors, and I think that that's very helpful when you are thinking about being more multi-level and think about planning. So those are the only thoughts I have.
Well, in the interest of time, since we are at the about top of the hour, I want to take the opportunity to thank Russ and Samantha for sharing with us and talking about the past 20 years of REAIM. Looking forward to the next 20 years and beyond. Thank you for all of your involvement in promoting and supporting and advancing the initiative. Samantha, a couple concluding remarks.
Yes, thank you all so much for your time. Just so you know, we will be taking a summer hiatus after this presentation, since May is always really busy with graduations and all of those things. So we'll be back in September with our webinar series. We hope to have another dynamic year. If you have a topic that you'd like us to discuss, burning question, it looks like 2 people were asking about cost, so maybe we can have a talk on that. Or if you'd like to be a speaker, we are always welcome. If you have something you'd like to share where you've applied REAIM in your work, follow us on Twitter. That's about it. So we'll hope to see you at the start of our new academic year. If you've missed any of our previous webinars or want to share them with colleagues, as you can see, they were all available on the website. So feel free to link people to that and link up with us. You know, one of the reasons we wrote this paper and have the website and have these webinars is we want to continue more dialogue so that we can have diversity in our thought and expertise and our target audiences. So please do reach out, because that's what we're here for.
Thanks, everybody.
Thank you, everybody.
Good job, you guys.